behalf of the authors of this paper. I have no disclosures. So central hypothyroidism is a rare disorder characterized by low serum free thyroxine or free T4 concentration and inappropriately low or normal TSH levels. Acquired central hypothyroidism is often part of multiple pituitary deficiencies, for example, due to compressive lesions, cranial surgery, or radiation, or even cranial injury. And you see here the hypothalamic pituitary thyroid axis, which we're all familiar with, is depicted here on the right. Congenital central hypothyroidism is usually part of multiple pituitary hormone deficiency, but can also be isolated. Both forms can be caused by genetic defects. Recently, immunoglobulin superfamily member 1, or IGSF1 deficiency, has emerged as a novel cause of congenital central hypothyroidism and is now considered the most prevalent cause of congenital central hypothyroidism. IGSF1 encodes a glycoprotein that is located on the membrane of various cell types, and its transcript is abundantly expressed in the rodent pituitary gland in testes, which is really important as we present the information presented here. And you see here on the right is the protein structure, courtesy of gene cards. Deficiency of this protein in the human male causes X-linked central hypothyroidism, disharmonious pubertal development, where you have normal timing of testicular growth, but a delayed rise in testosterone, and microorganism. In a variable proportion of affected males, other features are observed, including prolactin deficiency, partial and transient growth hormone deficiency in childhood, increased body mass index or BMI, decreased attentional control, mean increased FSH and growth hormone levels in some affected males. Here we present a male index case with central hypothyroidism, premature testicular growth, severe early onset obesity that was associated with a hemizygous non-cis variant in IGSF1. And you see here the actual defect is listed there. And a family with variable phenotypes observed in 4 male relatives carrying the variant, including normal free T4 concentrations. The proband was born full term after an uncomplicated vaginal delivery with a birth weight of 4,082 grams and a length of 52.1 centimeters. He was admitted to a neonatal unit for hyperbilirubinemia 4 days after birth. Newborn screening using TSH and T4 showed central hypothyroidism. And you see here the T4 was low to the normal 77.4, and it started at 7.4 micrograms per kilogram per day. Given the central hypothyroidism, an extensive pituitary examination was performed, which showed an undetectable serum prolactin level, normal serum levels of IGF-1 and cortisol. No structural abnormalities, though, were observed with MRI, or magnetic resonance imaging of the pituitary gland. At 2.4 years of age, he showed obesity with a BMI of 20.3, was 2.4 standard deviation above the mean. At follow-up, the patient had normal linear growth and further excessive weight gain was noted, with a maximum weight gain at 13.9 years when his weight was 152 kilograms with a BMI of 42.3, which is 163% of the 95th percentile in the US, or 4.2 standard deviation above the mean for a 1980 European reference. Thyroid hormone treatment was interrupted between 2.8 and 3.4 years due to the proband's mother stopping the medication, but had been administered since. She thought initially that she didn't need to continue the thyroid treatment because the thyroid function was normal. Serum free T4 levels have been maintained in the lower half of the reference range since that time. You can see here to the right, you can see here, this is a BMI chart, and you can see how his BMI continually increased with a peak here around 13.9 years of age. His testicular volume assessed with Prader orchidometer was 2 ml at 2.4 years, but showed a remarkable enlargement to 5 to 6 ml at a follow-up visit of 2.4 years. So these were pubertal testicular volumes, and he was only 3.4 years. However, on review of his blood work, he had prepubertal testosterone levels. And he didn't have any pubic hair or appearance of linear growth acceleration. At 6.3 years, a testicular ultrasound was performed showing a right and left testicular volume of 6.3 and 5.8, which is above the mean for his age at 4.2 standard deviation above the mean for age. The normal reference should be about 0.3 to 1.1. And still, even during this age, he had an absence of pubic hair and still had undetectable plasma testosterone levels. On the right here, you can see here how his testicular volumes had been increasing over time. And as the age went by, you can see here, these are the volumes here on the y-axis, on the age on the x-axis. And you can see over the years how his testicular volumes was always those of someone who was in puberty over the years and became larger and larger over time. A GnRH stimulation test showed prepubertal pituitary response with a baseline and peak LH of 0.09 and 3 respectively, and a baseline and peak FSH of 0.95 and 16 respectively. A borderline pubertal response to GnRH was first observed at 9.4 years old with a baseline and stimulated serum LH of 0.3 and 7 IU per liter respectively, and an FSH of 2 and 17.9 international units per liter respectively, when his testicular size was 10 to 12 mLs. So you see here, it was just very borderline pubertal response, but his testicular size was almost someone who was in mid-puberty. However, plasma testosterone was still undetectable, and baseline stimulated FSH secretion surpassed LH secretion. So he still didn't have a great LH response, although his testicular size was 10 to 12 mLs. A thyroid ultrasound was done at 12.5 years of age and showed a symmetrically small gland with an estimated volume of less than 1 ml for each lobe. A bone age was done, it was close to chronological age. So usually in a patient like this, you would, with this large of a test at this age, you would see an advanced bone age, but we're seeing bone ages that were close to chronological age, which supported the fact this testosterone was undetectable. Here is a little summary here from our paper that summarized some of the results we've talked about so far. You see here his bone ages stayed with his chronological age. Height SDS was appropriate. His BMI was continuing to increase as we depicted in the previous diagrams. His testicular volumes was also increasing over time. You see here 5 to 6 mLs that we mentioned, 8 mLs by 6.3 years of age, and you see it keeps on increasing. Free T4s, what's on treatment was normal. TSH remained normal and got even a little bit suppressed here. Prolactin levels undetectable. Testosterone levels undetectable. And levothyroxine dose was appropriately titrated based on his thyroid. We did Fragile X testing, which was negative. Methylation pattern of SNRPN was not suggestive of Prader-Willi syndrome. An array comparative genomic hybridization CGH was normal. However, on further evaluation, after doing some reading and collaborating with some groups, a pathogenic variant, nonsense mutation in the IGSF1 gene, and the exact actual mutation is actually listed here, was detected by Sanger sequencing. Segregation analysis showed the mutation was also present in 3 female and 5 male family members. And we'll talk a little bit about that family. So let's talk about the proband's older brother. So once we discovered that the proband had this mutation, and we started to look at the other family members, we looked first at his older brother. He was initially seen at the clinic at the age of 13 after the proband's initial findings. He had a normal TSH and free T4 newborn screening result. However, at presentations, he had central hypothyroidism. So he had a free T4 that was low and a TSH that was normal. But he also had a low plasma testosterone level in comparison to a testicular size of 25 to 28 ml, which is someone who is near the end of puberty. And he's depicted here in 3-1. His serum prolactin level, IGF1 concentration were normal, as was his height and BMI, and he did not have manifestations of long-standing untreated hypothyroidism. He was subsequently started on levothyroxine at 1 microgram per kilogram per day, which led to normalization of his free T4. The first male cousin, 3, which is depicted here, he presented at 20 years of age, and he showed central hypothyroidism, obesity, and extreme microorganism with 50 ml testes, and also had attention issues at school. His initial thyroid function study showed a low free T4 at 9.7. You see the reference range there. and inappropriately low TSH of 1.01. Thyroid function studies were repeated, showing a slightly higher free T4, which was just above the lower limit of the reference range of the free T4 assay in use at the time, with a TSH of 0.715. The patient did not, given his thyroid function, the patient did not start the levothyroxine treatment. The second affected male cousin, 3-6, depicted here, showed a free T4 just above the lower limit of the reference range with a normal TSH level, but he was also obese. At 14.3 years, his testes were of appropriate size range, about 10 to 12 ml. In an ultrasound, his testicular volume was 17 and 12 ml, which contrasted with the low plasma testosterone level, as we've seen in the other patients described here. There are also some peritesticular fluid and microlithiasis. The third affected male cousin, which is 3-7, he presented 11.4 years and also showed a serum-free T4 level just above the lower limit of the reference range, 12.7 picomole per liter, with a normal TSH level, and was also noted to be obese. He had difficulties at school with reading comprehension issues. At 11.4 years of age, his testicular volumes were 5.6 ml, but which were larger than expected for the pre-pubertal pubic hair tanner stage. The PROMET's mother and female cousin, who were heterozygous for the IGSF1 variant, showed a serum-free T4 of 12.98 picomole per liter and 16.73 picomole per liter, respectively. So you see, those were in the normal range. And their menarchal ages were 10 years, 11.5 years, respectively. And they both had normal menstrual cycles. So our conclusions were here. Excuse me 1 second. Sorry about that. On that side, it jumped off of the screen. Okay. So our conclusions. So here we describe a patient who presented initially with neonatal jaundice, central hypothyroidism, and low serum prolactin, and later showed severe obesity, premature testicular growth, disharmonious pubertal development, disruptive behavior at school, and microorganism. Genetic evaluation showed a pathogenic variant in the IGSF1 gene. Further evaluation of the family showed that the proband's brother and 3 out of 4 male maternal cousins carried the same variant. So what are the new observations here? So first, in virtually all patients with IGSF1 deficiency reported to date, the serum-free T4 concentrations decreased in combination with a normal or low serum TSH. In the present report, though, we showed that out of 4 male relatives of the proband, free T4 level was just above the lower limit of normal in 2 of them, and fluctuated in around the lower limit in the third case, suggesting that this may occur more often in males with IGSF1 deficiency than previously observed. Second, the start of testicular growth in the proband from 2 years of age was unusually early, possibly associated with relatively high serum FSH concentration before and after stimulation by GnRH. A similarly early onset, but less extreme testicular growth, 3 ml with prior organomer, with increased FSH has been reported only once in a 3-year-old boy, a hemizygous IGSF1 deletion. Excuse me 1 second. Third, although obesity has been observed in 21% of children and 17% of adult males, extremely early weight gain presented in this program is unusual. Only 1 previous report of a 2-year-old patient with IGSF1 deficiency showed such severe obesity. But in our report, obesity was observed in 3 out of the 4 proband's male relatives carrying the IGSF1 variant, so this was new. So our study indicated that male hemizygous carriers of a pathogenic IGSF1 variant can present with free T4 levels above the lower limit of the reference range, premature testicular growth without increased testosterone, and severe early onset obesity. This would imply that testing for IGSF1 should not only be considered in patients who have central hypothyroidism of unknown cause and low prolactin, microorganism, or delayed puberty, but also when free T4 is slightly above the lower limit of normal and in case of premature testicular growth or unexplained early onset obesity. We recommend to test family members in a pattern consistent with X-linked inheritance if a program is diagnosed with IGSF1 deficiency because of the indirect evidence that levothyroxine treatment has a positive effect. These are my references here. I'd like to thank my colleagues who helped in this study, and I'd like to thank again the organization for giving me this opportunity to present. Thank you.
Thank you very much, Dr. Stephen, for this interesting report. And I wonder if you have any question for Dr. Stephen.